Hi, Dr. Lee. We are here in Beverly Hills, and you are all going to meet Dr. Bruce Lee, who is the inventor of Acessa Procedure, and I'd love for him to tell us a little bit more about the procedure.
Well, thanks, Tara. It's great to be able to speak about Acessa, something that I feel very strongly about, and because I believe it offers women a much needed alternative to more major treatments for fibroids like hysterectomy. So, Acessa is an outpatient, minimally invasive procedure, meaning you come in, you have it, and then you go back home the same day. It's minimally invasive, meaning it's not a major surgery. There aren't any major incisions. There are still minimal risks to surgery, of course, but they are indeed minimal. And the recovery is very rapid. Most patients are able to return to work in 3 to 5 days. There's only 2 small incisions, one 5 millimeters and one 10 millimeters. So it's a fairly easy recovery as surgeries go. Also less risky because we're not opening the abdomen, for example, like hysterectomies often require. So it uses heat. Radiofrequency ablation is just a way of delivering targeted heat. And we can target that just to the fibroid so that the surrounding muscle and the lining of the uterus, called the endometrium, are preserved and they are intact. Fibroids are like rocks inside of a sponge. And as that rock grows, it compresses the sponge. And what we're doing is we're reversing that process. We're making that rock soft and smaller immediately by treating it with the heat, and then the surrounding muscle reabsorbs it. Just like the body is always remodeling itself, reabsorbing cells that die and creating new ones, we're just using that body's own mechanism to do that so that the fibroids will shrink and many will completely disappear. These fibroids do not return because they are immediately destroyed at the time of the procedure. Also, we can treat fibroids down to 2 millimeters in diameter, which is pretty tiny, because we're using laparoscopic ultrasound or ultrasound inside the abdominal wall cavity and right against the uterus. So we're able to then to put our needle right against that little fibroid, treat it, and then 10 years from now it's not going to be an issue. So the advantages of it is that it's very safe and effective. It's minimally invasive, rapid recovery, it's cosmetic, and it treats fibroids essentially in all locations.
So what's the difference between this and the other procedures that are out there for women?
The standard procedure for women who want to have children and have uterine fibroids and need help with their fibroids is called a myomectomy. And myomectomies today are usually done through an open incision like a C-section. And that involves cutting into the uterine wall to the fibroid, removing the fibroid, and then suturing that defect or hole in layers. So you destroy some muscle by making that incision. For example, if we have a fibroid your size of about 7 centimeters, we have to make a 7 centimeter incision at least. And so we cut through the wall 7 centimeters, then we take the fibroid out, and now we have to repair that in multiple layers with sutures that grab each side and bunch it together to stop the bleeding and to basically repair the hole. And that destroys more of the wall. So now we have quite a weakened wall in the uterus. Also, the cavity of the uterus may now be distorted because we've removed so much tissue now that the shape of the cavity can be very different. If the cavity gets entered, then that's a risk for scar tissue to develop inside, and that can prevent pregnancy. And then lastly, when we make that incision, scar tissue forms there afterwards, called adhesions, 80% of the time. So the intestine, the bladder, the fallopian tubes, ovaries can all stick there afterwards, and that can distort their function, and it could also cause pain. So myomectomies have good and bad. Good part is that you can take that fibroid out immediately today and it's gone. Bad thing is that you have the adhesions and you're weakening the wall, so cesarean section is usually needed after a myomectomy if that patient conceives. And lastly, you leave fibroids behind with the standard myomectomy because you're not aware of these smaller fibroids. Or you decide not to make multiple incisions in the uterine wall because you don't want to weaken it anymore. So fibroids usually are left behind, unfortunately, meaning those fibroids can be problematic in the future. So Acessa versus myomectomy, there are advantages to each, but I believe Acessa has more advantages, particularly for women who want to conceive.
And how about the UAE? UEA.
UAE.
UAE, I got it right. I did have it right.
Uterine artery embolization is a procedure performed by a interventional radiologist, not a gynecologist like myself. And a catheter is placed into the right femoral artery, or a tube basically, and that tube is threaded around to the right and left uterine arteries. And those are the two main vessels that feed the uterus. The uterus, however, also gets blood supply from the vagina and from the ovaries. And what happens is the radiologist will inject these plastic permanent beads that occlude the small blood vessels. The blood vessels then are not supplying any oxygen or blood flow to the entire uterus because these beads don't go just to fibroids, they go everywhere in the uterus. And the idea is that presumably the fibroids will die and the uterus will survive, which usually is the case, but not always. Sometimes the uterus is so badly damaged that it basically dies. The uterus is generally damaged enough so that we don't feel that having pregnancy afterwards is recommended. So it's generally not a procedure recommended for women who wish to conceive. Also, it doesn't work well for larger fibroids, and there is something called a post-UAE syndrome that occurs several days after the procedure, where women commonly have fever, abdominal pain, and elevated white blood count. And that's because you're blocking blood supply to the whole organ. It's basically like putting a tourniquet on your foot and leaving it there. Those beads also migrate elsewhere. They can go to the labia. Women have lost their labia. It goes to the buttocks commonly, so that there's pain there, and the beads have even been found in the lung, for example. So one more thing is those beads can also go to the ovaries, and if they do, then they can cause the woman to go into premature ovarian failure or menopause at an early age. 26% of the time that happens to women who are 50 years of age, about 1 to 2% of the time for women who are 40 years of age. So in general, because of all these reasons and the obstetrical complications that occur in pregnancy, UAE is not a recommended procedure for women who wish to conceive. But it is appropriate for women, for example, who can't undergo general anesthesia because their liver is too unhealthy, or they have kidney problems, or lung problems, or heart problems. That's where I think that this procedure basically lies. If I didn't have Acessa, if I didn't perform Acessa and I didn't know it so well, I would probably recommend more patients for myomectomy and UAE. But because I do have Acessa and I do see the patients enjoying the benefits of Acessa, that is predominantly what I do.
So Dr. Lee, being that I'm coming tomorrow for my surgery, what can I expect? What do I need to know?
First of all, you will be asleep. You'll be under general anesthesia. And that's because we will be moving the uterus about to turn it various ways to get to fibroids in every location. We know of basically one fibroid for you, about 7 centimeters, but most women have more. And the preoperative ultrasound usually only detects half of the fibroids. So if they say they're 5, we usually find 10, for example. Even MRI misses about 50% of fibroids. So we will be treating all of your fibroids, and you will be under general anesthesia. Okay. Once you are asleep, we will be breathing for you with the tube down your windpipe, and we'll be checking your oxygen levels and your blood pressure and your EKG, and we'll be monitoring everything so we know that you're safe. So you'll be very, very safe during that procedure. You'll also have a catheter called a Foley catheter in your bladder that I place after you go to sleep and I remove before you wake up. That's just to keep the bladder decompressed, and we can also monitor how your kidneys are doing in making urine. And lastly, I have an instrument on the cervix, and I move it so I can tilt your uterus and stabilize it. And when I remove that before you wake up, there'll be a small amount of bleeding vaginally, and so that bleeding again is from that instrument and not from treating the fibroids. Okay, and then once you wake up, we'll say, "Hey, Tara, we're done," and you won't have been aware that any time has passed. That's the interesting thing about general anesthesia. You blink, and then you open your eyes.
That's
and
fine.
We're all done.
I prefer that.
Right.
I've never been under before, so I prefer to not know a thing and not remember a thing.
When you wake up, you'll have a minimal uterine cramping, kind of like period cramps.
Mm-hmm.
There are just two small incisions, 5 millimeters and 10 millimeters.
Mm-hmm.
There's minimal discomfort from that because we'll be giving you IV Tylenol throughout the procedure, as well as an anti-inflammatory at the end of the procedure. So you'll wake up feeling pretty good.
Mm-hmm.
Mm-hmm.
So what I will feel cramping. There will be 2 incisions, and you'll show me where there's one will go through the belly button, and then the other one will be
down as close to the bikini line as we can get it.
Okay.
And that lower one is 1 centimeter, which is basically the breadth of the finger.
Okay. And I know I had emailed you about, cosmetically not wanting to have scars. So could you talk a little bit about that?
Sure. Basically, I close the incisions the same way the plastic surgeons do. And the incision in the belly button, you will never be able to detect afterwards. Mm-hmm. The one down in the bikini line, yes, you might be able to see it, but it's a very small one. Mm-hmm. And usually pretty hidden in cases like yours. Okay. You get a better scar if you avoid tight clothing on your incisions, so you avoid anything that rubs on them. We will put sutures there, and we'll also support that with something called steri-strips or tape that goes over it, and so that'll reapproximate the incision, and it'll be very, very cosmetic.
Do I need to have the stitches removed, or will they dissolve?
They are dissolvable, but I like to have them removed in about 8 to 10 days. Okay. Because I tie a little knot at the end, and I like to clip that off because I don't like putting the knot under the skin because it can lead to a hard spot there.
Now for me, being that I wasn't planning on staying 8 to 10 days, what do you suggest that I do?
Mm-hmm. You can go back home, certainly, and your GP can do this, or you can walk into a clinic and they can handle this as well. Just
it's not something where I need to go to a plastic surgeon. No. It's not. By then it'll be mostly healed.
It will be healed.
It will be healed.
And then you can take the tape off and clip these little loops of suture off at the level of the skin. Okay. It takes a minute.
And it's not like someone's shaky hand or bad technique is going to screw up.
No, it's already done.
Okay.
It's already been repaired. That's why we don't want to do it earlier.
Okay.
Some docs will have you come in earlier, but then, if you peel the tape off, that can break the incision open again. Yeah. So you just wait a little longer, and it doesn't do that.
Okay. Mm-hmm. So what's next for today?
Well, today we need to finish talking about fibroids in general to make sure that I've answered all of your questions. Mm-hmm. We've talked about what to expect with the procedure and what it will do for you and what we think it may not do for you, so that you have the right expectations. And I need to do a physical exam, listen to your heart and lungs and all, and do an ultrasound to confirm the findings of the ultrasound that you had before. Because often I find that my ultrasounds will find more fibroids.
Okay, wonderful. So, Dr. Lee, I was just saying that I am on my menstrual period. I'm just at the end of it, and I was hoping that wasn't going to be an issue. So please tell me what you just told me.
Well, it's actually the ideal time to do the procedure. The reason being is that the uterus increases in size, as do the fibroids, depending upon where you are in your cycle.
Ah.
It becomes maximally large right before your period starts. And then it shrinks down by around day 5 or 6, which is right about where we are, to the most minimal size. So your fibroid is now going to be the smallest at the exact time of your procedure. So your timing was literally perfect.
Oh, wonderful.
Now, if patients can't time it as well as you, we still can do the procedure. It just means the fibroids are just a little larger and takes a little bit more time to treat, that's all.
Okay. Wonderful.
But even if somebody is flowing, and some women flow so much of the month with fibroids that we can't time it to where they're to the right particular time, it still doesn't matter. We can still do the procedure just fine.
Now, will my period be disrupted? I did read that there will be some possible bleeding as I'm healing and discharge and things of that nature. What can I expect as far as getting back on my cycle?
The Acessa will not change likely your regularity. In other words, if you were every 28 days before, you should stay that way, because we don't bother the ovaries at all except to look at them and to photograph them to document that they're normal. So your hormones don't change. Okay. So, and your hormones dictate when you have your menstrual period. Fibroids don't usually cause bleeding. They can, but they don't usually. But they do make your periods heavier and more crampy.
Yeah.
So whatever bleeding you have is just frankly made worse by the fibroids. So now that we're going to treat them, you can expect your period to become lighter in the next 1 to 3 months. You can expect by the 2nd month to pretty much have no cramping, or almost no cramping, so it's not an issue anymore for you. And literally in 2 to 3 weeks, you will find your urinary frequency way down, so that you won't have to go to the bathroom so often.
And also, pain during sex is another symptom that I have.
Right. We generally don't advise intercourse for the first 3 weeks, just to allow healing to occur. But I have many stories from patients who I treated just before they got married, and they had wonderful honeymoons, let's just say.
Okay, so they didn't follow doctor's orders.
Well, we made sure that we had the procedure at least 3 weeks
3 weeks
away. So painful intercourse, or dyspareunia as we call it, is a very common symptom of uterine fibroids. And after this procedure, we don't see it.
Okay. And you have lots of women who have gotten pregnant.
We do.
Let's talk about that. So you have women that have gotten pregnant after, doing the Acessa procedure. And for someone like myself that, our situation with Michael's vasectomy, we may have to do the IVF process. And that's kind of what we talked through on the phone. How long would you suggest that we wait to make sure that everything is working and healed before I even went down that road?
I'll know better once I see the fibroid at the time of the procedure, because sometimes these fibroids can be very close to the lining of the uterus, and the closer it is to the lining of the uterus, the greater the chance of miscarriage. So fibroids that are further away from the lining, you can actually try to get pregnant fairly quickly.
Okay.
I've even told one couple, because she was older, to actually have intercourse in 2 weeks after the procedure, and she conceived that very month after 5 years of infertility. So it really depends upon what I see tomorrow, what that recommendation will be. However, in general, it's about 3 months.
Okay. So Guys, I wanted to show you what the findings were. This is my uterus. And we just did the exam, but please tell everyone about your findings.
We definitely found that there's a fibroid on the posterior or back wall of the uterus, and the uterus itself is flexed backwards toward the ground, so to speak, as opposed to being up, and that this fibroid is pressing right against the cavity, right against the lining of the uterus called the endometrium. And that particular kind of fibroid poses a greater risk for miscarriage. It also tends to cause heavier menstrual bleeding. Now, you don't have terribly heavy bleeding, but it's increasing, it's getting there. And certainly in time, that would be a really significant problem. So this particular fibroid, we have to be just very careful, which we are, just not to injure the endometrium, and that's a piece of cake. And now it's going to be taken care of, and it should shrink very, very, very well. I wouldn't be surprised if this fibroid completely disappears, and that you can go on it and conceive and
live happily
have
ever
your
after.
family.
High five.
So here's the capsule of it right here. You can barely see that white line here. So from here to there is what we call the sagittal measurement, or foot to head, and it's 5.0. And then from back here to here is the AP, or anterior posterior, and that measures 5.3. And again, remember, this is the perfect time of your cycle. So we expect it to measure smaller than it has in the past. And again, you were perfectly 100% in your timing. So transverse is here to there, and it's only 4.4.
Great.
Piece of cake.
Okay.
Very good chance this fibroid will shrink by 90+%, if not completely disappear. Okay, so we're going to measure longitudinally from here to there.
That's the uterus right there.
That's this from the cervix to the top of the uterus.
Okay.
And that's what we call the fundus right up here. Okay. And that's 8.8. Now we're also going to measure from the posterior to the anterior. And that is 6.4. And then we're going to measure from left to right, or transverse. And that dimension is 6.1. Okay, so that's the uterus. Not terribly enlarged, but definitely enlarged. Okay. And this is all the fibroid here. Okay. This is all the fibroid.
Wow.
And the lining, the cavity, is up here. So the fibroid appears to be in the back or the posterior wall.
Yeah, that I knew.
And it appears to be abutting right against the lining of the uterus. So this is one that we definitely would want treated before attempting pregnancy, because miscarriage is much more likely in this case. But that's why you're here.
Yeah.
Okay. So right up here is the lining of the uterus, right there. Okay. And there could be some smaller ones that I see here and there, but we'll know better. I'm going to look one more time.
Are you nervous? Why?
Because I've never been under before.
Okay. You're going to be fine, sweet pie. I mean, no problem. Piece of cake.
Having heart palpitations.
Take a deep breath.
I wish they can give me something now. Something to relax my nerves so the whole thing is seamless. Like, let's not wait. Give me this stuff now. Post-surgery, I feel extremely groggy, but not in a lot of pain as of right now. Just really dehydrated. But I think that it just feels like period pains. So that's kind of good.